Welcome back, Mateo County Dental Society. Today we head into San Francisco to interview our next speaker for May 31st. Just as a reminder, it's going to be on the 5th Thursday of the month instead of the typical 4th. One of the difficult things to do in our dental office is to help our patients diagnosing their dental pain. And so our speaker is an endodontist, and he's going to go over a lot of details as far as how to differentiate pulpal pathosis and non-odontogenic pain, and hopefully clear the air a little bit more for us. We welcome Dr. Ralan Wong. Today we are honored to have Dr. Ralan Wong. We are outside of his office here in San Francisco. He's been willing to give us this interview despite his busy schedule. So thank you very much. Can you tell us a little bit more about what we can expect to hear from your lecture that day?
Being an endodontist, we treat patients in pain, and one of the biggest things I found is dentists, students, any specialist that's out there that deals with dental pain, it's really hard to figure out what's going on. And that's one of the biggest things that I found that my referrals tell me is that we are good detectives. Yeah. And I tell my patients that really that's what we are, dental pain detectives. Because once we find out what it is, whether it's the root canal, extraction, a sinus issue, a neurologic issue, then we either send them back for a crown, send them back for a filling, get them to an ENT, get them to their medical doctor, neurologist, whatever it may be. So I think that's the most important thing, just that try to find out what's wrong, because you can't treat what you can't see. For sure. So you got to figure it out.
So with all the different ways to test pulpal pathosis nowadays, what's your opinion on using the electric pulp tester?
And I'm glad you asked me that. Electric pulp test is the absolute worst test you could possibly do. I was on the committee to write the state board exam. Okay. We wrote that question, and 46% of our students got it wrong. Wow. I think that it was such a good test, and that's the absolute worst test. Okay. Thermal testing is the best. Okay. Cold for sure. Sometimes heat, but yeah, EPT is the absolute worst.
Are there other testing ways out there that general dentists are probably still using that you would recommend not to use?
Yeah, one of the big ones are the ice pencils.
Okay.
Or a liquid ice. You know how you take a anesthetic cartridge, put a Q-tip, or freeze it right with water, and then use that. Well, the problem with that is that when it melts, it starts going backwards because your patient's tilting back, and then it goes back, and you can get another tube. Yeah. Sometimes it's not cold enough. So sometimes that's why endo ice is one of the best things. But then where to put the endo ice is another thing.
Location.
Absolutely. We talk about that, where to put it, because you want to put it as close to the pulp horn as possible, and there's reasons why. When you do heat tests, sometimes you have to actually put a rubber dam on the tooth because the water has to get underneath the crown or a filling in order for it to respond. So there's a lot of things to it. It's not just, 90% of them are pretty easy, but it's those hard ones. Yeah. At 10%, even for us, sometimes it may take me 30 minutes to get a diagnosis out of it.
Yeah. I mean, lucky for us, we have you to rely on, but it's funny to think that who do you rely on if you have those difficult, challenging cases?
Oh, I get those cases all the time because as a specialist and dealing with dental pain, and my referrals know they give us the hardest of the hard cases. For sure. So I have my colleagues and people that I go to when I'm stuck. Sure. Or people in pain, I have to say, where would you go next? And then usually we're on the right path, but I remember before they give me more ideas, so I've incorporated all those ideas into my practice now. And hopefully can give a couple pearls to your society and hopefully make it better. Yeah,
look forward to that. Is it pretty easy to differentiate fractured pain as far as fractured tooth pain? Is it different?
So fractured teeth, well, there's differences. So there's fractured teeth where they have a fracture and it's pain to bite down on, and you can have cold, and then sometimes you just need a crown. And then there's fractured pain where it's had a root canal already, and then it can respond to heat. And the reason why is because heat transmits down that crack and hits the periodontal ligament, and that's what makes it respond. But heat can also have a tooth that had a root canal and have a missed root. So that's what makes it difficult. And CBCs are not the answer. Everyone always thinks, oh, I can see a CBCT, go get a scan. Oh, Dr. Wong, he's got a scan. He can figure out. No, you can't do it. You can't do it by just looking at it. You got to have a test, and then it's about putting all those tests, putting those symptoms together, and then getting a feel for what it is. It's really not, and they always say it's not a science, right? It's an art, and I've learned that not everything fits in this category, right? Where it's an irreversible, it's irreversible, it's necrotic, it's a failure, it's fractured. It's like putting everything together, put it, you know what? Yeah, it is that.
Obviously, we like to be able to say that the pain comes from the tooth. So how difficult is it to diagnose with non-odontogenic pain?
Some of those are really, really hard because the patients will come in and they'll tell you it's a tooth. They'll tell you it's this tooth that's hurting, and they'll have all the symptoms, and you can test it, and you'd be like, yeah, maybe, maybe not, and it's really hard, and you just have to have a conviction. If it doesn't feel right, don't treat it. And like I said earlier, there's nothing wrong with waiting, because if it's a true tooth problem, it will come out.
How do you manage a patient? You do an excellent root canal, and you know you did a great job, but then the patient still says it hurts.
That's another one of the worst things that can ever happen. I mean, you've done everything you could, you find 4 roots, you feel it perfectly, airtight, and they're still symptomatic. And I have patients like that, right? And what do? Well, you say, okay, go back in, you get a cone beam, see if there's a root. Well, could it be cracked? Well, there's no pocket, it doesn't hurt, it just hurts. A lot of times we just go back and we medicate. So that's the first thing we do, just take everything out, calcium hydroxide. Sometimes we'll do it twice. Usually that will take care of it, because sometimes it's just a scar, sometimes it's just an irritation. And always remember, there is about 2% of people in the world who can't handle root canal.
So I had a buddy, an endodontist in San Mateo County Dental Society, that wanted me to ask, what's your opinion on an endodontist doing build-up?
First off, why not? We're all dentists, right? I have no problem with it. I know some endodontists, but as long as you know what to do, and as long as you are cognizant of all the new materials out there, and what your GPs do, I have no problem with it. When I first started out, I was doing a lot of just root canal only post bases. But my GP started knowing, like, oh, he knows what he's doing. He knows how to make a post base. Sometimes I was like, why don't you just prep the margin and then take the impression for me and then send it back ready for the crown?
I'm gonna have to talk to my endodontist. Well, it's great to have this interview and give the society an opportunity to hear a little bit about you. We look forward to hearing from you on May 31st. And thanks again for coming out. We look forward to having you lecture.
I look forward to coming out there.
Yeah,
Appreciate the opportunity.
Anytime.
Thank you.